Now, another important aspect of the carotid Doppler exam is comparing the waveforms between the right and left side, and especially for the common carotid artery. Here on the left side, we see a normal appearing carotid Doppler waveform. On the right-hand side on this patient, you can see it's higher resistance with an absence of end-diastolic flow. When there's a decrease in diastolic flow on one side compared to the contralateral side, that tells me there's distal disease, or disease that is distal to the point where I'm sampling. Now that could be an ICA occlusion, which is probably the most likely event, but it could also be that there is a stenosis that's intracranial, and the most likely location intracranial would be at the carotid siphon level. And in this particular case, it was just beyond the siphon, and we have this high-grade stenosis within the middle cerebral artery. Now, we won't see changes down at the common carotid from an intracranial stenosis unless the stenosis is at least 70% diameter reduced. And of course, this is much more than that. We can also appreciate these changes in the color Doppler waveforms. On the side of an occlusion, or a side where we have high resistance flow, we will actually see in the color Doppler very little end diastolic flow, and here you see some blue, and that's the reverse component. On the normal side, we see flow throughout the cardiac cycle because we have a low resistant waveform that shows flow throughout the cardiac cycle. So this is an ICA occlusion, and this is what we see with the grayscale imaging is a debris-filled vessel and an absence of color fill in this area. Now, another reason we might want to compare the right and left sides would be with proximal disease. And here we have on the left-hand side very low velocities, a tardus and parvus effect to the waveform. When you contrast that with the contralateral right side, we have high velocities, more normal upstroke to the right common carotid artery, and it's really quite different. Now, you might be tempted to think that the right side has a stenosis because the velocity is so high, but in actuality, this is just compensatory flow. The real pathology lies, in this case, on the left-hand side. Let's look further at this case, and if you look up into the internal carotid artery, you can see that the velocity is still low on the left compared to the right. There's an abnormal waveform on the left, whereas the right has a nice normal waveform. But look at how high the velocity is on the right. It's about 180 centimeters per second. Again, there is no stenosis on the right. This is compensatory flow. When we look at the vertebrals between sides, both have high velocity flow, no stenosis. This is compensatory flow. Now, I can determine this is not stenotic, number one, because I know that I have high-grade pathology on the left, which I'm going to demonstrate to you in just a moment, but also because there is an absence of any type of post-stenotic turbulence in these other vessels that would have to be used to help determine that we have a stenosis. When there's stenosis, we see a focal acceleration coupled with post-stenotic turbulence anywhere in the body. Focal acceleration coupled with post-stenotic turbulence. That's not the case with compensatory flow, and that's not the case in this situation. In fact, in this situation, what happened is we even have reverse flow in a branch of the external carotid artery, antegrade flow in the internal carotid artery. There's a high-grade stenosis at the origin of the left common carotid artery. That's the real culprit in this whole situation. And if you look at the angiogram, you can see the bifurcation is patent. There's no stenosis here, but if you notice that the ECA is not really filling, and that's because it has the retrograde flow that we've just documented here in this color Doppler image. Lastly, we want to make sure that we keep our mind on the study, paying close attention to the numbers that we're generating throughout the study. This can be challenging when we have tortuous vessels, as in this case, this is a patient with a coil, and as we Doppler sample around this, we're going to be using a variety of Doppler angles, and if we're not careful, we'll get quite a range of velocities. In fact, in this case, proximal to the region of the coil, I had a velocity that was about 70 centimeters per second. And then as I moved into the coil, all of a sudden the velocity jumped up to 112. this didn't really make sense to me because there's no stenosis, no narrowing. Actually, it was just an angle correction error, and when I lift off the probe or update the image, I could see that I had moved slightly, adjust the Doppler angle very carefully for the area that I'm in within this coil, and I have a good velocity. So it was really closer to 79 or 80 centimeters per second in this area, not 112. Now, as I came around the coil, continuing to sample, all of a sudden I get a velocity that's 48 centimeters per second. Again, this makes absolutely no sense. It's an angle correction error. Even though the image looks like the angle correction is accurate, it's not. You update the image, double check the location of your sample volume, angle correct to the walls as it curves around. It's challenging to do, but making sure that the velocity values make sense. And sure enough, when I do this, my velocity is 70 centimeters per second, and that's more accurate. So in reality, in this coil, my velocities ranged from about 70 to 80 centimeters per second, never from 70 to 112, just down to 48. That doesn't make any sense. So keeping your head in the study and making sure that the velocity values that you're generating throughout the study make sense is very important. We also want to make sure it's telling the right story, again, that everything is making sense beyond just taking Doppler samplings in tortuous vessels or coils. This is a case that was done by one of my students, and after she did the study, she asked me to help her because she was concerned that maybe she hadn't really told the entire correct story. And my first input to her just on this image, it looks like there is probably a high-grade stenosis, but there's too much aliasing. And if you look at the velocity scale, the numbers here are quite low, which means that the velocity scale and or PRF and velocity scale are two words for the same thing. The PRF is set too low. It needs to be raised so that we can really appreciate some of the flow without all of the aliasing. Next, when she sampled in the common carotid artery, it looked like it was a very high resistance waveform and low velocity. And it looks like the angle correction is good, but she's sampling in the middle of the vessel, but not in the middle of the flow. So I really feel like the sample location is not correct. It should be in the middle of the flow. And the image is so dark that I really can't appreciate whether or not there's plaque in this area, which there was. And then the highest velocity she got as she sampled through the internal carotid artery was 200 centimeters per second. This could be right, but I'm suspicious that the velocity is probably much higher than that because when I have such a low velocity common carotid artery with high resistant flow, I would expect an even higher velocity reading in the stenosis. And in fact, this area of stenosis looks to be much tighter than that. So we brought the patient back down to look again, and as suspected, when we looked at the highest velocity in the internal carotid artery, it's actually closer to 400 centimeters per second rather than 200, so nearly doubled. And part of that had to do with the sampling location. She had not walked the Doppler through the entire area. She was sampling actually just distal to the area of maximum stenosis. So by going back and forth and walking through there, I was able to pick out the highest velocity more accurately. And you can see here an angiogram that shows this very high-grade stenosis, consistent with the findings. With that, I think the last thing that I wanted to say is just to enjoy your work, and I'm recognizing the staff that I've worked with for years and years at Baptist Hospital and Baptist Medical Center just right outside of Memphis, Tennessee. Performing carotid Doppler is one, it's a very rewarding study. It's an important study, but close attention to detail is key to success and key to obtaining the proper diagnosis for our patients. Thank you very much.